In this video, we are going to cover flowcharts and diagrams from the chapter of aortic stenosis. So, table 1, the major causes of aortic stenosis. So, the common cause of aortic stenosis in the younger population are the congenital cause, like the bicuspid and unicuspid valve, or it could be rheumatic fever. And in the elderly, the common cause is degenerative calcific diseases. And other cause of aortic stenosis could be radiation. So while reading any table, try to focus on the point which you can forget during the examination, like the radiation over here. Then coming to the severity grading of aortic stenosis. Only focus on the severe aortic stenosis and the rest you can come to the conclusion afterwards. So the valve area. So the normal valve area of aortic valve is 3 to 4 centimeters square, and severe aortic stenosis is the valve area of less than equal to 1 centimeter square. So if this valve reduces, the size reduces, it is known as severe aortic stenosis. So the more this size decreases, the speed of the blood that goes through it, it also increases. So the peak velocity of more than or equal to 4 meter per second is known as severe aortic stenosis. And because of this stenosis, the gradient in between the left ventricle and the aorta, this increases. So the ventricle has to pump more and has to create more pressure to push blood into the aorta. So if the mean gradient is more than equal to 40 millimeter of mercury, this is known as severe aortic stenosis. Now coming to the other two, in the moderate aortic stenosis, the wall area is defined as 1 to 1.5 centimeter square, peak velocity of 3 to 3.9 meter per second, and the mean gradient of 20 to 39 mm of mercury. And in the mild aortic stenosis, the valve area is defined as more than 1.5 centimeter square, peak velocity of 2 to 2.9 meter per second, and the mean gradient of less than 20 millimeter of mercury. So this severity, in this, only the severe aortic stenosis is the one that you should remember by heart. Now coming to the follow-up of aortic stenosis. So if a patient comes to you and you have to follow up that patient. So if the patient is having severe aortic stenosis, then you have to follow him or her every 6 to 12 months. For moderate, it is 1 to 2 years, and for mild, it is 3 to 5 years. So only remember the first digit. That is, for severe aortic stenosis, it is 6 months. For moderate aortic stenosis, it is 1 year, and for mild aortic stenosis, it is 3 year. Now talking about the staging of aortic valve stenosis. So stage 1, it is at risk population. At risk means the patient who are having bicuspid aortic valve, or the patient who are having aortic s- sclerosis. Okay, this is sclerosis, it is not stenosis. So if in the question the patient is having aortic sclerosis, the patient is in stage A, that is he's at risk of developing aortic stenosis. Then stage B is defined as progressive mild to moderate disease, and stage C is severe aortic stenosis, and stage D is symptomatic severe aortic stenosis. So most commonly people confuse that stage B is mild, stage C is moderate, and stage D is severe, but it is not like that. Okay, because stage C as well as D both are severe aortic stenosis, and stage B is moderate to severe, and stage C and D both are severe aortic stenosis. So what is the difference? So you know about the stage B, what is mild and what is moderate. But in stage C, the patient is fulfilling the criteria of severe aortic stenosis, but the patient is asymptomatic. And this stage C is further divided into C1 and C2. If the ejection fraction is more than 50%, then it is stage C1. And if the ejection fraction is more than less than 50%, then it is stage 2. And in stage D, if the gradient is high, then it is known as D1. And if the gradient is low, it is classified further into D2 and D3. D2 is known as low flow and low gradient. And here the ejection fraction is less than 50%. and in stage D3 it is known as low flow and low gradient, but here ejection fraction is more than 50%. So which one is severe? It is D3. Although here ejection fraction is more, but what happens is once the aortic stenosis worsens, the ventricular thickness increases. So this is the ventricle. So with the severity of the aortic stenosis, the ventricle thickness increases. So the volume which it can take inside it, it decreases, and that is why the ejection fraction paradoxically is high, because of that low volume which it can take inside, only little amount is pushed outside. So although the ejection fraction increases, but the net ejection volume is very less. So although ejection fraction is more than 50%, the volume is very less. Okay, so stage D, D1, D2 and D3. Now coming to the treatment part. So you can divide the treatment into two. One, you can say is the patient symptomatic or is patient asymptomatic. Okay, so if the patient is symptomatic, then we will follow this algorithm. If not, then we will follow the algorithm on the right side. So let's see the algorithm for the symptomatic aortic stenosis patient. So if the patient is symptomatic, it means the patient is automatically in stage D, right? And if patient is symptomatic, then no need to remember the other thing, just straight away go for aortic valve replacement. Okay, and if the patient is asymptomatic, then there are two possibilities, whether the patient is in stage B or the patient is in stage C. So first thing is, if patient is undergoing any surgery, then you should also plan for aortic valve replacement along with that cardiac surgery. Okay, so if in stage C as well as stage B, if patient is undergoing any surgery, go for aortic valve replacement as well. Then the next thing, what is the ejection fraction? If the ejection fraction is less than or equal to 50% and patient is having severe aortic stenosis, that is stage C, then also you should get the patient aortic valve replacement. And doing the serial monitoring, like in the first diagram that we have seen, that if the patient is going follow up and the ejection fraction is persistently decreasing and it is less than 60% in three or more studies, then also you have to get him the surgery. And during the exercise tolerance test, if BP decreases or there is decrease in the exercise capacity, then also you have to get him the surgery. The other thing is if Vmax is more than 5 meter per second, or BNP is more than equal to 3 times the normal, or there is rapid progression of the disease and the patient is having low surgical risk, then also you should do the surgery. Now the point is which valve to choose. Okay, like we have two options available. One is surgical aortic valve replacement and the other one is transcatheter aortic valve replacement. So the only thing you should remember is, if the patient is young and uh, there is low comorbs, okay, low comorbidities, and if the life span or life expectation is high, then we will prefer the surgical aortic valve replacement. Okay, so this is the thing that we have to follow for any patient that is asked in the examination. So, uh, so forget all this. Just remember, if the patient is less than 65 year, okay, it means the patient is fit and healthy. So we will plan for surgical aortic valve replacement. And if the patient is more than 80 years, then it is transcatheter aortic valve replacement, which is preferred. And in between the age of 65 to 80 years, we can go for SAVR or TAVI, but SAVR is preferred over TAVI. Okay, and if the anatomy is not visible for TAVI, like we have to go through femoral vein in this procedure, and if the if the arterial anatomy is not good, then we have to go for surgical aortic valve replacement. Now, this is the last table in which it tells about the factors favoring SAVR or TAVI or palliative care patient in aortic stenosis. So only there are certain points that you should remember. So first in this column we have the surgical aortic wall replacement, and here it is trans catheter aortic wall replacement. So just remember the point that SAVR is favored in the younger patient where the life expectancy life expectancy is high, and this is and TAVI is preferred in patients who are elderly, who are old, and with low life expectancy. So in the younger patient it is SAVR, and in the elderly it is TAVI. So in the younger population, the common cause of aortic stenosis, it is bicuspid aortic valve, and it is subaortic calcification or rheumatic diseases. Okay, whereas with aging there is calcific trileaflet aortic stenosis, and in the younger population it is the mechanical or the surgical bioprosthetic valve that is preferred, whereas in the elderly it is the bioprosthetic valve, because if we are using bioprosthetic valve the requirement of anticoagulation decreases, and in the elderly there could be a risk of bleeding. That is why the bioprosthetic valve is preferred in the elderly. And if there is any concurrent cardiac conditions, okay, then like the mitral regurgitation, or if there is severe coronary artery disease, or if there is requirement of any surgery per se, then if we are going for surgery, then it is better to let the patient have surgical aortic valve replacement. And in the non-cardiac condition, if the patient is having multiple comorbidities like the severe lung, liver, or renal diseases, then we will prefer the transcatheter aortic valve replacement. And in the frail patient, obviously it is TAVI. And apart from that, if there is more complications of surgery, then we will prefer the TAVI over SAVR. So this is the basic that